At the edge of an international border, at the edge of the Pacific, at the edge of innovation, community, education, and discovery, you're listening to At the Edge of It All, a University of San Diego podcast where USD experts speak on topics and stories that impact you and the broader community.
Hi, I'm Melissa Martinez.
And I'm Elena Gomez.
And today on the podcast, At the Edge of It All, we speak with Dr. David Solomon.
He is a professor that specializes in nursing and diabetes, and he tells us a little bit about why he got interested in studying diabetes and really breaks it down for everybody of what diabetes is, how it works, and how you can stay healthy.
Let's take a listen. Professor, I'm very excited about speaking with you today. We were talking off mic earlier, and you had a very non-linear journey to where you're at today, right? Mm-hmm. Take us back to your upbringing. You're from the Philippines, right? Talk to us about that.
Yes, I'm from the Philippines. We migrated here in 2012, and my preparation is not really nursing to begin with. I was a business stat major. Statistics. And I was in a car accident during the start of my program, which made me delayed to progress through, and I just decided to kind of stop. And that pause in my journey took my vision to healthcare, which I found very interesting. And I felt I was young enough to jump into another field, which, that started my interest in the healthcare, and nursing was the most popular and I would say easiest to get into at that point.
What was it about your experience after your car accident that really kind of changed your whole trajectory? Like knowing, this is what I really want to do.
So first, when they brought me to the, I would say, kind of urgent care or emergency room where I was treated, the nurses that were there they were scary. Like, even if I wasn't in the medical field, I know the things that they were doing might be not on the safe side. And I felt like there was no advocate for me at that point. And after that particular moment, I am blessed to have a family with physicians. And my recovery process was, personally observed by my uncle or my cousin, who are both physicians in the Philippines. And I just got exposed to different things. I had to go to doctors. I had to get treatment, get prescriptions and stuff like that. And I had to recover. And that point was the, that aha moment for me that, I want to be in this field. I want to be able to take part of it, improve it where I can, as part of the workforce.
Another aspect of kind of your trajectory of where you went in nursing, because you studied diabetes, was also connected to sort of family, right? And how you were seeing diabetes in your family. And that's kind of the path you took within nursing, right?
Yes. So I think that one will have a different starting point because this was even before I got interested in healthcare. So we grew up with my grandmother, who's a stroke survivor. And we take turns, watching over her at night. And it evolved with us seeing, a family member, our family doctor come in and then check the blood sugar. And then we prepare her meals too. So we were instructed, what to limit. If you're giving rice, only this much. And give their medications before they eat and stuff like that, even if I didn't know what those medications were. And then at one point, I just heard that, your blood sugars are getting better. Took her off the medications, and I knew that diabetes is somehow manageable at one point. I didn't have all the details, but we were checking the blood sugar. We knew it was improving. There had to be some change in what you eat. Those are the three things that I kind of stuck with me even before I entered healthcare. And when I entered healthcare, diabetes has been my main focus ever since.
That's very interesting. I know that we hear the term diabetes all the time, but for people who don't have a loved one who has diabetes or they've never experienced it themselves, what is diabetes? I think there may be some misconceptions to those who don't know. Could you explain to us exactly what the condition really is?
So I would say the short version would be diabetes is a metabolic problem wherein your body can't process sugar. And when I say sugar, not just the sugar that you add to food, but anything that becomes sugar when you eat it, like carbohydrates. So, and when I try to give this analogy to my patients, it's more like you got a new car that runs in a different kind of fuel. And diabetes, in most cases, patients think that they can still continue to put the same fuel that they got used to and still be okay with it. And that's why when you try to force carbohydrates, sugar in a patient with diabetes, they will have no energy. They will have fatigue, because it's the same thing that happens to a car if you put the wrong fuel. It wouldn't start. Or at most, it might be, if it's like a dirty kind of fuel, you will feel it when you in the performance of your vehicle. So that's, I would say, the problem. And 90% of diabetes causes is from lifestyle. It's how much you move and how much you eat, basically 90%. And I'm talking about the lifestyle acquired diabetes, which is type 2. There's another type of diabetes, which is a very small percentage of the entire diabetes population, would be the type 1 diabetes, wherein it's more of an autoimmune problem. There's something wrong with your body's genetics that attacks the pancreas specifically, or the insulin. So in those cases, it's not lifestyle, but
Right.
90% it's lifestyle related. And a lot of people would just think that diabetes, oh, your sugar is high. It's not about that. It's sugar that's in your blood that's stagnating. And what I tell my patients, like, imagine if you had 2 spoonfuls of sugar, keep it in your mouth the whole day, and no, don't swallow it, don't spit it out, just keep it there. Imagine all the changes that happens inside your mouth. How would it feel 24 hours later? So think of that, and now think of it being inside your body.
That's a very interesting analogy.
So it's like, you can imagine all those damages, right? And you can also think of the different ways your body will respond to the high sugar. Number one would be a very, stimulated appetite. And I say this because a lot of patients with diabetes are hungry all the time. That's because there's so much sugar in the blood that the body cannot burn. So the body can't burn the sugar, meaning their appetite's still stimulated, like it's on hyperdrive. Without knowing what to focus on, they'll be stuck in that cycle of eating the wrong thing that worsens the condition. But it's like fighting against your instinct. So this is one of those realizations that I try to bring up in every visit. And most of the time, patients are not just aware of it. And that's just one component, the appetite. And if I would go a little bit further, you would have a gut. Your stomach is tuned into absorbing as much as carbohydrates and sugar as it can, as fast as it can, because it feels like you don't have the fuel. So it's like, oh, we don't have energy. Let's keep absorbing. Now you have a heightened appetite with a body designed to kind of absorb the sugar as fast as it can, but it can't use it. That's the second part. And all people know about diabetes so far, it's just my blood sugar is high, right? And then I add a little bit more. The third one would be the kidneys. The kidneys typically help the body release some of that sugar when it's spiking up so high. But when you have diabetes, the kidneys don't recognize that. They think they need the sugar, so they try to conserve the sugar and not release it because they think they need the fuel, where in fact you're poisoned with so much sugar already.
And what is happening to your kidneys when that happens?
So same analogy of that sugar in your mouth, all of that sugar crystals scraping through the kidneys, each heartbeat, because each heartbeat goes through the kidneys. And if your sugar is so high, I always tell my patients that imagine a liquid that's so sweet. Think of something very sweet that's a liquid. So I usually come up with examples like honey or syrup. Mm-hmm. Get it out of the bottle, pour it out. How does it go out of the bottle? Does it flow? It doesn't flow, it oozes out.
Right.
So instead of your blood circulating and flowing freely in your system, your blood is now oozing through. So it's like, that's the second part that, that's how we get these complications. That's why people go blind. That's why people get dialysis, because of those kind of complications. And then the last part that I usually tell them is that part of diabetes, when it progresses, is that your own insulin production goes down. Because this is a disease of chronicity, which means it's long-term. You don't get it overnight. You don't develop diabetes because you ate in a buffet today.
Right.
It's years and years of abuse with our system. So each time you have a carb-heavy meal, what happens is that your pancreas, which releases the insulin, tries to accommodate. If you ate how many burgers, how much carb portions you actually took in the meal, your pancreas will compensate with that amount, and multiply that effect to how many years. That pancreas will be overworked by the time you actually get diagnosed with diabetes. So by the time you get diagnosed with diabetes, when your A1C meets that threshold that you'll be classified as with diabetes, your insulin production is very low. And that's the reason why we have to limit these carbohydrates, not really eliminate them, but limit them. Know how much your body can now cover. And I go back to the analogy of, if they're working, what would you feel if you work in a department, you used to be 100 people, let's say you're a shoe factory that is supposed to meet 1,000 pairs a week, but 50% got fired, laid off for whatever reason, and now you're down 50% of your manpower, but your quota is still the same. 1,000 pairs a week. And cut that further, because the 50% got overworked, cut it down further, you're down to 20%, same workload, because lifestyle's never addressed. 1,000 pairs a week. There will come a time that you will have, the factory there with no production at all. And now you could come to a point wherein you can't tolerate any form of carbohydrate. That could be a scenario, and each person is different in that standpoint.
Professor, you have done more in the last 5 minutes to make me want to
I am
not
rethinking
eat
everything.
a single carb-heavy meal
Yeah.
than anybody in my entire life has done. Very, very good at describing what is happening in the body. I know about diabetes. I've read stuff, but really just the way you explained it to me just makes so much sense. Because I think some people do always hear, it's sugar in your blood, it's sugar in your blood. But what does that mean? This is actually what is happening inside of your body. How educational. I am just in awe. I'm so glad that there's medical providers such as yourself that are so, involved in trying to change people's education level on these types of diseases. Now, what happens once a person is diagnosed? What are the sort of things that you have seen from moderate to worse if they're not in some sort of treatment with a physician on this?
So the struggle I see, because I work in endocrinology, is that we get these patients too late. They've usually been treated for years and years, and then when they finally give up, I don't know what to do with you, let's send you to endocrinology, where in fact we should be getting these as early as diagnosis, which is the recommendation.
But are these patients having symptoms when they're going to the doctor and then they try different things and then they send them to you? Are they...
Yes.
Do they know that this is what it is, or?
A lot of times they've known they've had diabetes, but the understanding of the disease process is not there, because there's what we call a next pill approach in most provider settings. And I don't blame people who actually have this approach, because sometimes they go by the guidelines, they go by their time limit. Can you imagine? Sometimes you have to see 30 people in your shift. And then all you can do is look at what medications they're on and, what can I do? Are they meeting goal? If not, what can I do next? And the knee-jerk response of a lot of providers would be, okay, you're not yet on this medication, so we put this other medication, which gives a notion to a lot of people with diabetes that diabetes has a cure. It's like there's a medication for it. There are medications to manage the symptoms, to help you avoid complications, but there's no cure for diabetes. That's one thing I hammer down when I teach patients with diabetes, that there's no cure for it. That's the bad news. There's no cure. It's not like an infection where you finish this for 10 days and then you're cleared.
You can't reverse it.
That's another tricky word for reversing, because when you say reverse, a lot of people would think, oh, I can go back to
how it was.
how it was before. And I tell them, you can't get better in the same environment where you got sick. So when you say we reversed it, you were able to finally adapt to the lifestyle that keeps all your symptoms stable. All of your numbers are at goal. You understand why you're taking these medications. And that for me is reversal. Reversal doesn't mean that you're completely off medications, although I've had patients who were able to be off medications. And that first patient of mine is my dad. So he started off with medications for diabetes, and again, same approach, not much on lifestyle. It's more of like the next pill. So when I told him, do this, do that, and then watch your sugar carefully, and then once he was able to streamline that, we tried to wean off one medication after the other because that was his goal. And then eventually, now he's completely med-free, I think, for a couple of years now. So will I consider that reversal? I would say that's managed,
Right.
because reversal gives a wrong impression
Right.
that they
The wrong idea that you can
I'm
go
cured.
back to. Yeah.
You can have a patient who get that pancreatic transplant, get a new pancreas, but if they didn't change the way they ate or their lifestyle, that pancreas will give up too. Because I get very rich patients who would, can I buy a pancreas? It's like, can it be replaced? Yeah, if you replace it and don't change the way you're just
Right.
repeating the story.
Right.
You get a new start, but you'll end up with diabetes in the ending
Right.
as well. So those are a couple of things. And one of the things that I advocate for when I teach my students who would see these patients in the primary care setting is that you won't have time to educate all these patients. So look for people who are certified in, teaching them about these different aspects, because there are a lot, and Medicare, the major insurance that pays for this, covers up to 10 hours of education for patients every year. Not just in a lifetime. Every year you can get 10 hours, I think. That was
That's so important to know.
That was the last reimbursement that I recall that they cover. And guess what? I think the utilization of diabetes education is less than 2%.
Because people don't know about it, right? That they're not shown where they can get more resources and information.
Or
Maybe you think?
Or the providers don't know about it too.
Right.
Right. So I read this article. It says, if education was a pill, would you prescribe it? So, and I treat it that way. Like, are you meeting your goals for your blood sugars, for your blood pressure, for your cholesterol? If there's any point there that needs changing, the next thing I look at, have you been counseled in terms of lifestyle modification? If the answer is no, or if it's been more than a year, let's go back to your diabetes specialist for this, so that you can review, refresh. And I think that's what makes my practice unique, because I am certified in diabetes education. So I wear two hats. It's like I can see where the patients come from. I can teach where they are. And then at the same time, I'm a nurse practitioner by license, so I can prescribe it. So I think it's a very important skill for all providers to have that. And it's been a passion of mine to incorporate it every step of the way. Like the courses that I teach, I put like diabetes
Right.
in between, and then where to get resources and how to coach these new providers where to go.
Right.
As we wrap up, what are some tips you have for people at home? I mean, I think a lot of times when we hear of diabetes, we also think it's a genetic thing, and I think a large part of it might be. But what are some tips for people? Because this seems like you said, it's not overnight. This is a long-term thing for those people that are maybe not living the healthiest. What are some tips you have to kind of make sure you're preventing getting diabetes?
So I would want to go back to that, like family, right? It's like genetics. While it has a role in terms of how susceptible you are in developing a metabolic condition, the main reason or the main thing we inherit is the lifestyle.
I was going to ask you that. Is it really genetic, right? Is there a... No, I mean, you said earlier it was really lifestyle and how you eat and how little you move, and that's mostly what affects it.
You can look into different studies wherein it would show that if you take a certain ethnic group and get their diabetes risk in their own, culture, and then put them in, a Western culture with like what we eat here and stuff like that, their risk becomes the same. So there's a huge bearing in the lifestyle, really. But there is also some influence in how your body responds to sugar. You would see that too. One patient actually reaches 300 with the same sushi that this patient only
Right.
reached 180 in terms of blood sugar. So I would see that there is a genetic component on
Right.
how the body burns the energy, like how
Right.
fast your metabolism would be. But I always go back to the point wherein I hear patients, oh, diabetes run in my family. And I tell them, nobody runs in your family. That's another thing.
You have the best
Oh
one-liners.
my goodness.
So
Wow.
that part, like how your family eats, you inherit that,
Right.
and sometimes you pass it on
Right.
to your own family.
Right.
And it's a huge component. So it's identifying those decision points
Right.
again, because sometimes these decision points are a blur to you. You form them early on in your life. When I say decision point, what you usually eat for breakfast, for a
Right.
snack, for lunch, for dinner. These have been like what you were raised with, what's
Right.
available to you. And at one point, you no longer think. It's breakfast, I'll just grab that bowl of cereals. Because you grew up with that. That's a decision point that you no longer even pause to acknowledge. So that's one thing I go back to when I tell my patients, how do you reduce this risk? Go back to those decision points and, look at it. Is it something that is helping me get better, or is it worsening my condition?
So one question I have for you is like the normal person sitting at home or in their car listening to this or watching this episode, like when can you tell that you're crossing that threshold of just, oh, maybe I'm just not that active, maybe I don't eat like that well every day, but like when will it become an issue? Like when can a person who may not have diabetes running their family, is there a way to tell? Is there a way to say, oh man, if I go past this weight, or if this happens, then I'm going to be in that group of people that will have to watch out about this?
So there are blood tests that we do which are recommended by your primary care provider. So key is always having that checkpoint at least once a year. If you don't have a history of diabetes, meet with your healthcare provider. At least those annual blood exams can at least give you, I would say, this is what I call my patients, my smoke alarms. You have the ABCs of the smoke alarms. A would be for the A1C, which is a blood test to check your overall blood sugar average over 3 months.
Is that something you have to ask for specifically, or is it a routine physical that you do every year?
It's part of routine if you meet the age or the body weight that's in the guidelines. They would definitely order it for you. But if a lot of these patients don't see doctors. They
Right.
don't see their physicians
Right.
or providers on a regular basis. So typically they would go in when they're already feeling the symptoms.
What would be some of those?
Excessive thirst, weight loss, some with urinary tract infections, and other scenarios would be it so severe that they actually end up in the hospital. They're stroking out or having a cardiac event already, because usually diabetes won't have symptoms until you're way inside the disease process. So it's one of those silent things that can develop insidiously, and then all of a sudden when it pops up, you're way advanced in the process.
And what happens when you're not taking care of diabetes? What are some of the things that you have seen, so that people get an understanding of what could happen?
So going back to that blood flow analogy, anything related to circulation is really the problem. When you have high sugars, the tendency to form plaques, within those blood vessels, your arteries, your veins, they kind of double up. And it starts with, your blood pressure going up. Okay. And that blood pressure going up can lead to, those plaque building up. And you would see that people with higher blood sugar tend to develop twice as much cardiovascular events, because of the sugar and fat are not the best combination. So you can choose one, or it's like if there are people who can tolerate high fat intake but not high sugar at the same time. Okay, so when I would say sugar and fat molecules are best friends. That's what I tell them. When they meet in the blood, they hug each other. They hug each other. They become a heavier molecule, and they deposit. And they build those walls, in terms of that causes your heart attack, that causes your stroke, that causes poor circulation on the legs, leading to those foot infection and eventually amputation. They can block up the blood flow going to the kidneys, leading to dialysis. But these are all the horror stories, and
Right.
they've heard this several times.
Right.
It's more of what can you do about
What
it?
can you do?
Because a lot of times it's not about the scare approach. If you don't do this,
Right.
you'll end up with dialysis. It's more of what can you do? Because a lot of times they've tried. It's diabetes management is a full-time job on top of your full-time job, because you have to check your blood sugar, you have to watch what you eat, and you have to be conscious with how you move. So it's constantly building these healthy habits one at a time. That's what I tell them. You can't conquer the entire thing. You can't rebuild your lifestyle. And the reason why a lot of these lofty New Year goals don't really click, it's because we focus too much on the outcome. You focus on the weight, you focus on different things, right? Instead of focusing on the process.
Right.
Wherein lifestyle changes, it's a process. You can't just
Yeah, I
do it
remember a
overnight.
trainer saying once, because I was like, oh my God, I have to go work out for an hour. You start thinking about that whole hour, and he's like, why do you have to work out for an hour? You can do 15 minutes, and tomorrow you can do 16. And the next day after, you know what I'm saying? Like something that's more manageable to each individual than just thinking, for sure, I have to work out for this amount of time every day, or else it's not going to be worth it, you know?
So I do, when I coach my patients, I would start with what are the healthy habits that I would want them to actually have. And to build these, to make them stick, it's usually starting where they are and what they're currently doing. Right? Let's say I want this patient to check their blood sugars. I won't just add it to them like, okay, you have to check your blood sugars this many times. I would ask them, we need to check your blood sugars. How many times do you think you'll be able to check it? I think I can do once a day, and I can negotiate twice a day. But the book would say they have to check it 4 times a day. But if they would only agree to my 2, I'll take the 2 versus the 4 that the book recommends.
Right.
And then I would say, okay, what's the first thing you do in the morning? Oh, I pray, I get my Bible, or I brew coffee, or, whatever first thing that's already established, I attach that new task to that habit already. So when you wake up, do you brush your teeth? Put your glucometer, your blood sugar meter, beside your toothbrush. That way, when you toothbrush, you remember, oh, I have to
Right.
check my blood sugar. Same thing. If they have to inject a medication or take a pill before a meal, I would tell them, where do you usually eat? Can you put a sticky note there that you have to take this medication 15 minutes before you eat, or inject it before 15 minutes before you eat, something like that. And it's the same thing with the physical activity. You can't just include a workout 2 hours a day out of nothing, right? So I tell them, it's not about exercise, it's about movement. Can you move? That's what I ask them, because a lot of times people would think exercise, oh, gym membership,
Right.
Zumba class.
And it could be overwhelming, to think to be able to do that.
And I see patients who have multiple health conditions, not just diabetes.
Right.
Sometimes they have bad arthritis on the knees, so they can't really go walking. So I ask them, what movement can you do? And I start from there. So I think the main driving force of my philosophy is I start where the patient is and see what can you mold? What can you mold to, to actually do that particular thing that will benefit your health down the line. So it could be as easy as, walking 30 minutes still looks a lot for a patient, but I would ask them, can you walk for 10?
Right.
Can you walk for 10 after each meal? That will still be 30 minutes.
Right.
30 minutes is sometimes hard to include,
Yeah.
to protect as a whole chunk of time. But, after each meal, can you do a 10-minute walk? Set a timer. And then after that, you completed your 30 minutes for the day. We're in the American Heart Association only requires you to move about 45 minutes, 5 days a week.
Well, I gotta
So,
get on that.
So if you have 10 minutes every meal, you get 30 minutes a day. And if you do that for all your meals,
Right.
7 days a week, or you can even aim to just do it 5 days a week.
That's
You're
such
still-
a great strategy.
Yeah.
And I know we have to go, but lastly, I do want to ask you the importance of educating the educators. Right? Like you're here a professor at a school of nursing, and you are a very special part of the education process of those who will be tending to patients in the future. What do you have to say about those professionals who are thinking into going into the nursing field, and something as simple as diabetes management and telling their patients about it and finding resources for them can go a long way, right?
Yes. So for those in healthcare, I usually tell them that diabetes management, there's no cookie cutter. And a lot of times we're stuck to that. We're stuck to a guideline. This is how you treat pneumonia. This is how you treat asthma. You have that fixed mold, you fit it, and then, you try to fit the patient into the mold. Whereas you look at the guidelines and start with the patient, and how can you meaningfully apply that guideline to what the patient is actually willing to do, and they have to understand the value of it. Because you're just a prescriber. You can prescribe all the things you want, but if the patient is not in, there's no buy-in from the patient you're treating, it becomes fruitless. You won't get your outcomes, basically. And it's very hard, because even as providers, you feel like you're working so hard and you see the outcomes not being met. It's discouraging as a provider. So when you see that it clicks, they have that aha moment that finally they can do something that makes sense to them, that benefits their health. It's so satisfying as a provider too. And I want my students to feel that when they actually get that success story from their first patient, that they were able to navigate the complexities of diabetes care, and it just becomes the starting point for the next one.
Well, thank you so much. It's been wonderful having you here. I have learned more on this podcast than I this is fabulous. And I hope people who are listening to the podcast, who are watching the podcast, can take the great and valuable information that you have given us here today.
Awesome. Well, thank you so much for being with us. And if you like this episode, be sure to subscribe to catch our next one.